Good afternoon, and thank you for joining us today. I am Nikki Harris, Training and Education Lead for the Center of Excellence for Behavioral Health and Nursing Facilities, and it is my pleasure to oversee the delivery of mental health and substance use disorder trainings and education to nursing facilities nationally at no cost to the nursing facility. And now it is my pleasure to introduce our presenter. We could not host the live virtual trainings without our knowledgeable presenters. Today's presenter is Mark Sanders. Mark is an international speaker, trainer, and consultant in the behavioral health field whose work has reached thousands throughout the United States, Europe, Canada, the Caribbean, and the British Islands. A renowned author of 5 behavioral health books, Mark has been a certified addictions counselor for 34 years. He is also the co-founder of Serenity Academy of Chicago, the only recovery house school in Illinois. I'm now happy to turn it over to Mark. Thank you.
Thank you so much, Michelle, and thank you so much, Nikki, and good afternoon, everyone. Our presentation is addressing co-occurring disorders in nursing facilities, and we begin with the definition of a co-occurring disorder. And then we will articulate like 7 ways substance use disorders and mental illness overlap with someone that has a co-occurring disorder. We've explained the differences between 3 types of co-occurring disorders treatment. You'll be able to provide services and make referrals based upon the resident's level of readiness to change, and you'll be able to provide support for residents with co-occurring disorders. About 4 years ago, I was flying in from Arizona to Chicago, where I live. And on the plane next to me was a man who had earned 6 Purple Hearts. And how do you earn a Purple Heart? I'm glad you asked. Bravery. He was about 95 years old, a World War II veteran. In other words, for 3.5 hours on this flight, I was sitting next to the bravest human being I ever met in my life. And at one point he asked, Mark, what do you do? I said, I'm a social worker. I give speeches. I talk to counselors, therapists, case managers, nursing home facility specialists, medical doctors. And he told me to tell you, thank you for your service. Thank you so very much for your service. Know that I know that the world cannot compensate you enough for the important work that you do. I'm in my 41st year as a certified alcohol and drug abuse counselor, and people often ask me, how have I done that work for 41 years? So I'll share with you a story, and then we'll get deep into our content. It was March of 1986. I was sitting in my office downtown Chicago. The phone rang. A man called me collect. He was in tears. He was crying. He said, I need to see a counselor today. I looked in the appointment book. I said, I can see you in an hour. He said, it will take 8 hours. My office was located downtown Chicago on Jackson and State Street. He lived on 103rd Street South. He walked 103 blocks to meet with me, 103 blocks. Was he motivated? He had gotten paid that Friday and spent his whole paycheck on cocaine. So he called me collect at 9 o'clock on the Monday morning. I did the assessment. I said, are you ready to get help for cocaine? I'm ready to get help for cocaine. I said, if you leave my office and go and stand on the corner of Jackson and State Street, a bus will appear. Take the bus to the end of the line. At the end of the line, there's a drug treatment center. He said, I don't have bus fare. And I was about to reach in my pocket and give him bus fare. And then one of my professor's voices came into my head. We're not about charity, about helping people help themselves. Give a man a fish he eats for a day, teach a man a fish he eats for a lifetime. You ever heard that before? I reached in my pocket and gave him bus fare. He walked 103 blocks. I waited for the bus. I paid his bus fare. And then I whispered, end of the line, there's a drug treatment center. He came back a year to the day that I gave him that bus fare and gave it back and said he was grateful for his recovery. And what I've learned in my 41 years is that if you help someone transform their life with a co-occurring disorder or with a substance use disorder, Eventually, gratitude sets in. And once they become grateful, they start helping people. And then those that they help out of gratitude start helping people. And then those that they help out of gratitude, they start helping people. It basically means that your important work in this area never ends. Again, thank you for joining us. We begin with the definition of a co-occurring disorder. Two coexisting disorders, independent of each other, but yet interacting with each other. Each is characterized by denial and ambivalence and is treatable. I decided that I wanted to share with you some good news within the 6 minutes of our presentation, because I wasn't so sure that we would actually get to this good news at the end. So here's the good news. Long-term studies indicate that if a person has an addiction, a substance use disorder, if they don't die prematurely of that substance use disorder, that 75% of them will enter recovery. That 75% of them will enter recovery. Remember the 1980s, there were these stars that were like the poster children for addiction, for substance use disorders, individuals like baseball player Darryl Strawberry, who was addicted to cocaine. He's now in long-term recovery. Do you remember an actor by the name of Robert Downey Jr.? Now he's in long-term recovery. Do you remember a singer? Of course you do. By the name of Elton John. He spent the 70s and 80s high every day. Now he celebrates 32 years of recovery. You know one of his greatest acts in recovery? He reached out to a young rapper from Detroit named Eminem, and he helped Eminem. And now Eminem is celebrating 12 years of recovery. You see, so the research bears out what I just said, but I can give you an example up close from my own family. The year was 1986. I was giving my first speech. There was a knock on the door. There's a Mark Sanders here. You have an urgent call. Who knew I was there? My mother was on the phone. She said that my dad had just died in a closet at work, and he was smoking the drug of his choice, cocaine. 29th, 1986. A month later, my Uncle Isaac went in front of a judge one more time and pleaded for treatment instead of incarceration. This time, let's put my Uncle Isaac in treatment. The program called our 13 aunts and uncles, invited them to participate in my uncle's treatment. They said, no, we don't like him. He stole from us to buy heroin. The counselor called back and told my aunts and uncles, we have food. They said, we'll be there. So all 13 of them participated in my uncle's treatment. Then they invited 26 nieces and nephews, 39 of us. He entered recovery in 1987. We count 30 people in our family who've entered recovery since. If it does not take out their life, 75% will enter recovery. We also know, and I'll whisper this for dramatic effect, that the research says that 1/3 of individuals with severe mental illness will remit. In other words, you saw them when they were in their 20s and they had active schizophrenia, but the research says that when you follow up with many of these individuals in their 60s and 70s, now living in retirement homes, homes for older adults or nursing facilities, that many of them, you can't distinguish them from an individual who never had severe mental illness. 1/3 remit completely. 1/3 of individuals with mental illness make some progress. So that's 2/3 right there. And then 1/3 stay about the same. So each is characterized by denial and ambivalence and is treatable. When mental illness and substance use disorders coexist, both should be considered primary, and treatment for both disorders is needed. Let us chat. Can you find your chat feature? And here's your question. When you are working with someone that has a co-occurring disorder, that is a substance use disorder, what we traditionally call addiction, and mental illness, which should you address first? Would you put either in chat the substance use disorder or the mental illness? Which should you address first? And I'll check in with you, Nikki, to see what people are putting in chat. Thank you all for joining us.
Mental illness, mental illness. All right, we're seeing substance use disorder. We're seeing both, unless one is more severe. All right, we're seeing both. All right. So a variety of responses here, Mark.
Thank you so very much. And let me weigh in on my own question. When a person has a co-occurring disorder, there's only one place you can start. And that's where they let you start. If they let you start with addressing mental illness, you start there. If they let you address the substance use disorder, you start there. It's where they ultimately let you start. The research suggests that substance use disorders and mental illness overlap at the rate of 50%. So if you are working with a resident that has a substance use disorder, according to the research, easily half of them have a concurrent mental illness and vice versa. If we go back to our definition, at the top it says two coexisting disorders independent of each other, but yet interacting with each other. Here's your question, let us chat. When a person has a co-occurring disorder, how does mental illness and substance use disorders interact with each other?
Waiting on responses, Mark.
Yes, yes. How do the two interact with each other?
Someone said, please repeat. All right, I'm seeing some of the responses here. All right. The substance abuse may be self-treatment for the mental disorder.
Yes.
Mental illness can exacerbate SUD and vice
Yes.
versa. They play off of each other. Drugs can exacerbate the mental illness.
Yes.
All right. They are dual of each other. All right. And dependency on substances to maintain their mental illness. All right.
Okay,
We
very
have a
good.
few
These
more.
are, go ahead, I'm listening, Nikki.
All right. Drugs can be used to self-soothe.
Yes, these are really great answers. I'd like to just add a few to your list. Marijuana can be used to medicate psychotic symptoms. I work with young men in Chicago who are gang affiliated, who smoke marijuana every day. And they swear to me that marijuana has medicinal properties. And they swear that it's automatic and natural to smoke. These young men tell me that God created marijuana. It grows in the earth. It's a plant, and everything God created, these young men told me, is good. And guess what I discovered? There's some research out of Europe that talks about a cannabinoid in marijuana called CBD. And all of you have heard of CBD. And they've extrapolated CBD from marijuana and put it in solid form. And what they found is that CBD, in many instances, does a better job than psychiatric medication in addressing psychotic symptoms. What we mean by that are hallucinations. The most common types of hallucinations are auditory, where you hear things other people can't hear. Visual, you see things other people can't see. And the third type is called tactile, while you feel something is crawling on your skin. There's also delusions, which can be a part of psychosis, where you have this sort of fixed belief about something, in spite of evidence that it can't be true. You have a resident that runs outside in January. It's 100 degrees below zero. They're not wearing a shirt and they tell you it's summer. Or I work with some residents that have what we call delusions of grandeur. They've never flown before, but they believe they can fly. So they go on top of what we call the Sears Tower in an attempt to fly. They found that CBD has an impact on some of these symptoms, minus the side effects. The only problem is, I talk to the young men I work with who are under age 18 who smoke marijuana every day. Marijuana also has THC, which many of you all, the young people I work with, are addicted to. Alcohol used to medicate the grief caused by mental illness. We had a client years ago. We called her the cheerleader in our residential facility. Every night at 3 a.m. She would put on a cheerleading outfit, pick up some pom-poms, and she would start to cheer. And she would wake up the other 24 clients, the other 24 residents that were asleep at 3 a.m. She would also wake up the staff that was asleep. That's right, in your nursing facility, people work midnight, get a little sleep, and it's unnatural to be awake those hours. So the staff would go into the cheerleader's room, and she would start to cry. The staff would call a psychiatrist, and the psychiatrist would say, let's increase her medication. So one day I asked the cheerleader, would she share with me her life story? Not her intake, her life story. When she was a senior in high school, she was valedictorian of her high school graduating class, and she was captain of the cheerleading team. She went from a Chicago public school to UCLA in California on an academic and cheerleading scholarship. At age 19, while on the college campus, she started hearing voices. At age 23, she's in our residential facility. I had an epiphany. Every night, when the cheerleader would put on the cheerleading outfit and pick up the pom-poms, start to cheer, and then she would cry, she was grieving. And what she was grieving was the life that she had before schizophrenia set in. We work with lots of individuals who have severe mental illness, who are grieving the dreams they had, and will often use substances in order to cope with that grief. So her psychiatrist said, let's increase her medication. There's not a pill in the world that can treat grief, not one. Depression, yes. Anxiety, yes. Not grief. Drugs used to avoid the side effects of psychiatric medication. What makes a drug is medication. I promise you that easily a third of you have some pills in your medicine cabinet at home that you never finished. They've been in there for 21 and a half years. You never finished them because the side effects were greater than the benefits, right? So we had a client that they told us that before bipolar disorder set in, she was on a pathway to become a supermodel. So they prescribed her medication for bipolar disorder. And there were two effects to this medication that really harmed her. One, it made her thirsty. So she drank liquid all the time and started gaining weight. And then number two, it made her walk in a stiff manner. Her gait was really stiff. So no, I'm gaining weight, she said. Look at my walk. I don't walk like a supermodel. So she stopped her psychiatric medication. She started using cocaine instead. Alcohol minimizing the effectiveness of medication, increasing the risk of overdose. So when a person drinks alcohol, the liver is the organ in the body that breaks down alcohol. The same with pills, the same with medicine. Given the choice between breaking down alcohol first or the pills, what will the liver choose? Always the liquid. So what that means is that a person who's drinking constantly, the medication may be building in their system at toxic levels without being metabolized, leaving them vulnerable to overdose death. Did you know how many people would overdose and die if drinking alcohol also didn't control the vomit response? And then you've seen people who drink heavy and they urinate a lot from drinking lots of, say, beer. So they may be flushing the therapeutic benefits of the medication out of their system through frequent urination. You all talked about this earlier, that drug use can exacerbate psychiatric symptoms. So you're working with a resident who already experiences depression. They start drinking alcohol heavy, which is a central nervous system depressant. They become more depressed. They experience some paranoia. They use meth or crack. They become more paranoid. The medication of drugs can be used by some residents to medicate feelings of uselessness. And so broken promises, broken dreams, right? I don't believe I can make it anymore because of mental illness, and I feel useless. And so I started to use alcohol and other drugs to medicate that horrible feeling. Then, of course, alcohol and illicit drugs can make it difficult to follow mental health and alcohol treatment regimens. People who suffer from mental illness often experience more serious symptoms when drug and alcohol use is involved. Increased intrusive thoughts, increased feelings of hopelessness, a lack of motivation or fear of being in public places, etc. And of course, there are a ton of warning signs that a person might have mental illness or substance use. And again, as I mentioned earlier, they overlap at the rate of 50%. So we begin to look for some of these signs. These signs are not enough to allow us to make a diagnosis, but they allow our antennas to go up. We begin to suspect, is there mental illness, is there substance use disorder, or a combination? We want to take a moment to talk about 3 types of co-occurring disorders treatment. There's what we call sequential treatment. The resident receives services for mental illness and substance use disorders one at a time. So in other words, they might spend 3 months in mental health treatment, complete that program, and then spend the next 3 months in substance use disorders treatment. We call that sequential treatment, one at a time. There's also what we call integrated treatment, where the resident receives services for mental health and substance use disorders in the same facility at the same time. Integrated, both under the same roof at the same time. The third type of co-occurring disorders treatment is called concurrent. The resident receives services for mental health and substance use disorders in 2 different facilities at the same time. So let me ask you a question. Which of these 3 types of co-occurring disorders treatment do you think is the least effective? Which is the least effective? Sequential, integrated, or concurrent? Which is the least effective?
We see sequential. Sequential, okay, all right. Seems like that is the consensus.
And you are absolutely correct. Because at least with concurrent treatment, the person has their eye on services and healing from both at the same time. The biggest challenge with concurrent treatment is that the 2 facilities where they're receiving services might have conflicting views on approaches to treatment on something as simple as Valium or Xanax. There are many addictions professionals who believe that Valium is a central nervous system depressant that's in the same family with drugs like alcohol and barbiturates. Thus, many of them believe that if you take Valium or Xanax, you will develop a high tolerance for those drugs because you have a high tolerance for other central nervous system depressants like alcohol or barbiturates. Then the mental health facility believes that Valium or Xanax are anti-anxiety drugs used to treat anxiety disorder. Who's correct? They both are. So if you have residents that were receiving services in 2 separate facilities, in an ideal world, your staff will get updates and be able to attend case staffings in both facilities just to assure that their philosophies aren't negatively harming the other program's approach and philosophy. Obviously, concurrent falls in the middle, and integrated treatment is the most effective. So let's take a moment to talk about some of the components of integrated co-occurring disorders treatment. Psychoeducation. I believe the ideal person to provide psychoeducation for clients, for residents with mental illness, are the psychiatrists, the ones who know the most about medication and mental illness. So in psychoeducation, the resident receives information about subjects like the biological basis of mental illness, the idea that there's some psychiatric disorders that run in families, like depression and like bipolar disorder, right? In other words, it's not your fault. These conditions run in families. Education about the brain, how medication works in the brain, diagnosis and how diagnoses are made. Here's some criteria for the diagnosis we think you have. What do you think? Psychoeducation is about medication and how it works in the brain, the side effects of medication, and what to do should you notice side effects. What we've learned is that the more educated the resident is, the better decisions they can make about their mental health. Family psychoeducation, because the family has lots of questions too. How can we be most supportive? Is it our fault? They have children. Are the children vulnerable? What should we do if they become demanding? Intensive family case management to help with entitlements for the entire family. Assertive community treatment. Some of you are aware of assertive community treatment. Its goal of this evidence-based practice is to keep clients from, or residents from having to access residential facilities or enter the ER when they decompensate psychiatrically. So there's a team. On that team might be a case manager, a recovery support specialist, a social worker, an RN, and they go out, particularly working with residents who are, or those clients with co-occurring disorders who are homeless, and they provide outreach services to decrease the number of psychiatric hospitalizations. Assertive community treatment as a part of integrated treatment. Identification of goals and purpose in recovery. So here's the story. In 1997, my youngest brother called me and said, I have a drug problem. I said, I know. My brother said, I need help. I said, I know. So I put my brother in detox for 3 days. He called me on the third day and said, I'm bored now, what do I do? I said, go to a meeting in Narcotics Anonymous. And my brother called me after his first NA meeting in tears. He was crying. I said, why are you crying? He said, after the speaker spoke at the meeting, I looked at the speaker and I said to the speaker, you spoke the truth. I was there. I remember you. The speaker is a man who used to sell drugs and use drugs with my father when my brother was a little boy. You spoke the truth. I was there. I remember you. The speaker went to my brother and said, you don't know this, but as soon as your dad died, smoking cocaine, I got into recovery. There's a famous expression that some people die so other people can live. And you certainly don't know this. When I was out there smoking drugs with your dad, he saved my life twice. Your dad saved my life twice. He said, so often ask God, why did you save me? Looked at my brother and said, maybe one of the reasons I was saved is so that I can help you. He was talking about purpose in recovery. Do you know that when I first became a mental health specialist, we thought that all individuals with severe mental illness wanted to do was pace all day, scratch lottery tickets all day, smoke cigarettes, drink coffee, and watch television. But what we're learning is that they want goals and a sense of purpose like everyone else. There's a woman named Nanette Larson. I hope that one day you can meet Nanette Larson. Nanette Larson is the director of rehabilitation services for the state of Illinois. She has a master's degree in psychology and a public story of bipolar disorder. So she goes around helping people that have severe mental illness find their purpose in recovery, discover their goals in recovery. She taught me person-first language. Person-first language is really important. So she was meeting with a group of clients that were diagnosed with schizophrenia. And she said to them, you're not schizophrenic, you have schizophrenia. There's more to you than that. She said, that'd be like somebody who has herpes, syphilis, gonorrhea, and chlamydia saying that they are herpes, syphilis, and chlamydia. There's more to you than that. What are your goals in recovery? So we're learning language like you're not an addict. You're a person with an addiction, a person with a substance use disorder. You're not homeless. That's a permanent state. You are a person transitioning from homelessness. What are your goals in recovery? We now have a role. It's called the recovery coach, the peer-based recovery support specialist. These are people in recovery from substance use disorders, mental illness, and co-occurring disorders who are now on purpose. They're helping other people. We're talking about integrated co-occurring disorders treatment. It's important to collaborate with community behavioral health resources, those that provide the resources to address co-occurring disorders, which your program may not provide. Medication management and in consultation with the nursing facilities, medicating physician. We will take a moment to talk about what I'm calling stage-based interventions. Two psychologists, one named Prochaska, and the other one's name is D. Clementing, from the University of Rhode Island, identified what's called the 5 stages of change. The first stage is called the pre-contemplation stage. The person does not believe they have a problem that needs to change. I tend to call the pre-contemplation stage the clueless stage. The clueless stage. Isn't it true that when a human being has a problem, often the whole world can see it before they can see it? Isn't that true? I have a first cousin who always dates the wrong person. You ever met someone who always dates the wrong person? He took the wrong person to junior prom. And I can always tell when my cousin is in a bad relationship because her mother, my aunt, will call me and tell me. 6 years ago, my aunt called me and said, Mark, she's done it again. I said, what, aunt? She's got into a relationship with a loser. I said, you meet the person? They know I saw a picture of him. I said, wait a minute, you looked at a picture. You knew this guy wasn't a winner. We met him that Thanksgiving. He wasn't a winner. I'm only serious. She knew looking at a picture. It took the daughter 3 years to see what her mother saw. And then 3 more years in the relationship. Always a gap between what we see and what we do. The second stage of change is called contemplation. It's also called the ambivalent stage, where the person has mixed feelings about whether or not they want to change. You know the ultimate ambivalence? You give a resident a psychiatric pill, a psych med. They cheek it. They put it right in their jaw. What they're saying to themselves, if I swallow this pill, I'm agreeing with the psychiatrist that I have schizophrenia or bipolar disorder. If I don't swallow the pill, it means I don't have mental illness. Ambivalence, mixed feelings. The third stage is called readiness. The resident is motivated to change, and they haven't initiated change yet. The fourth stage is called action. The resident is actually changing. They may be taking medication, going to 12-step group meetings, meeting with a recovery coach. They're changing. Staying out of bars, staying out of crack houses. They're changing. The fifth stage is called maintenance. When a resident is in the fifth stage, they've been in recovery and dual recovery for 6 months or longer. Let us chat. Most of the residents that you work with who have a co-occurring disorder, when you first start working with them around their co-occurring disorder, what stage are most of them in? When you first begin the work.
Contemplation, ambivalence. All right. Pre-contemplation, contemplation, pre-contemplation.
So Nikki, the group was correct. They're in those first 2 stages. The problem is sometimes you refer that resident to treatment and they're giving a treatment plan that looks like this. You leave our facility, we want you to go to 90 12-step meetings and 90 12-step group meetings in 90 days. We want you to work those 12 steps with a sponsor. We want you to go to one like non-drinking, non-drug using activity per week. You also don't have your GED. We want you to go to GED classes 5 days a week. You're unemployed. We want you to apply for we want you to take job readiness classes 5 days a week. We want you to apply for 10 jobs per week. You have depression. We want you to take medication daily, meet with a case manager daily, see a social worker once a week, right? And meet with a psychiatrist once a month. Anybody who does that entire treatment plan is probably in action or maintenance. This particular resident is in contemplation. You know when resistance occurs? When you work with someone that has a co-occurring disorder. Resistance occurs when you expect the person to be somewhere they're not in terms of these stages. If we really accepted people where they were, there'd be no resistance. It occurs when I expect you to be further along than you are. Now, it's rare for a person with a co-occurring disorder to be both in maintenance in both disorders at the same time. I've worked with people who, in terms of their substance use disorder, are in action. In terms of mental illness, they're in pre-contemplation, and vice versa. The goal is to inst them alone until these two conditions line up with each other. So we want to spend a few moments talking about supporting residents who have co-occurring disorders. I'm going to pause then after we do that and see what questions that do you have. And make your questions really hard so we can have a rich discussion. And then I'll say some word in closing at the end. We'll have a big close at the end. You know, there's a woman by the name of Tonier Kane. And Tonier Kane has a public story of having been abused so many times as a little girl, sexually abused so many times she lost count, sexually assaulted as a woman, sleeping outside underneath a bridge for 2 decades, and arrested 68 times with 66 convictions. She's now in long-term recovery, one of our nation's foremost trauma experts. And she suggested that I suggest to you that as long as there's breath, there's hope. As long as there's breath, there's hope. Important to treat all residents, including those with co-occurring disorders, with dignity and respect. Be patient. Sometimes residents with mental illness psychiatric diagnosis, may need time to process instructions. Get to know the resident. Find out what brings them comfort. And keep in mind that anger, irritability might be a sign of withdrawal, maybe a sign of the condition. Ask the resident, allow them to take the lead if they have a co-occurring disorder, how you can be most supportive. Consider whether a change of environment, maybe a new treatment facility, may be necessary or helpful. Help the resident plan in advance what they'll do to help them feel better. We're talking about a wellness plan. Identify and partner with organizations within your community that support co-occurring disorders. We want to make sure that it's important that we listen and have empathy and have patience. I have a friend named Greg Risberg. And Greg Risberg started off as a 4th grade teacher. The backdrop of where he taught 4th grade was Robert Taylor Public Housing. He went from being a 4th grade teacher behind public housing to a social worker to a motivational speaker. And Greg told me that one day a man called him at midnight and woke him up and asked, "Are you the same Greg Risberg who taught 4th grade across the street from public housing 30 years ago?" And Greg said, "Yeah, that's me." He says, "I was a student in your 4th grade class. You were my teacher." He said, "I'm a decorated military man. In fact, I wouldn't be surprised as a military person if I wouldn't wind up achieving the rank of a Colin Powell. I was just calling you to tell you really made a difference in my life." And Greg said, "What did I do?" He says, "Every Friday you would stop teaching and you would sit the whole entire 4th grade class in a circle and you would have us to read the newspaper from cover to cover. And in reading the newspaper from cover to cover, what I learned, there was more happening in the world than simply what was happening in public housing. So it made me curious about the world. So I heard him graduate high school. I joined the military. I went around the world twice, he said. But you did something that was more special than that. One day you invited the entire 4th grade class on a special field trip. You invited the entire class to your house. And you asked everybody to bring a bag lunch to your house. And I looked at my refrigerator that night and I saw that we had no food. And when I made your house with no food, you went in your refrigerator and you fixed me a sandwich. He said, "Anyway, the reason I'm calling is because we still have a home in Chicago. And I'll be coming home next month. And I wanted to invite you over to my house so I could fix you a sandwich. When he told me that story, it dawned on me that it took him 30 years to see the fruits of his labor. When you treat co-occurring disorders, when you address co-occurring disorders, you're like farmers who plant seeds, who may not see the fruits of your labor in the season that you plant the seed. And sometimes it takes many seasons. 75% of those with a substance use disorder will enter recovery if we can help them to stay alive. A third of people with severe mental illness will remit totally. You never know they had that condition. 1/3 make progress. 1/3 say about the same. Patience is of the utmost importance. And in the meantime, celebrate small victories. You haven't used in a whole month. Let's have a celebration. You've been meeting with your case manager daily for like about 5 months. Let's celebrate that, right? And encourage the residents to celebrate those victories too. Reduce stress. You know why? Because a leading cause of relapse, individuals with a substance use disorder, is stress. A leading cause of psychiatric decompensation is stress. Have hope and provide a sense of community. People always make more progress in recovery if they have a sense of community. Other residents working on recovery, non-residents in the community who are working on recovery. Make sure the organization's policies and procedures are aligned to address co-occurring disorders. It's also important to assure that all staff receive training on co-occurring disorders, that all staff receive education about harm reduction. Harm reduction was developed in Amsterdam in the red light district, where they legalized prostitution and found that the spread of HIV and sexually transmitted diseases decreased, crime decreased. So we brought harm reduction to the United States. And we started using harm reduction strategies with individuals who have substance use disorders. Let me suggest to you that a resident is more likely to overdose off of the opiates when you put them in residential treatment and then they return to the nursing facility. Or they go to jail for 30 days and then they return to the facility. Or they leave the nursing facility and they go and move with their family. They're more vulnerable to overdose at that time. Do you know why? Why are they more likely to overdose when they leave treatment after being there for a month or so? Leave jail, leave your facility, and return to the community.
Temptation and availability, change of environment, triggers,
There's one big one.
stress and less accountability. They're
There's a
being
big one.
exposed to their
There's a big
triggers
one.
again, change.
This is gigantic, Nikki, here, what I'm about to share. What they found is that when a person has been away from the drug, like the opiates, oxy, heroin, right, fentanyl, when they've been away from it for a while, their tolerance drops. So they go back to using what they were used to using, and they're vulnerable to overdose. Harm reduction is about reducing the harm connected to use. You know that one of the smartest things that we can do for someone who's using illicit drugs or even legal drugs, like Valium, Librium, Xanax, and barbiturates, right? If they also drink alcohol, right, is to discourage the use of alcohol with those drugs. Here's why. They found that in nearly 70% of cases, when a person dies of an opioid overdose death, heroin, oxy, right, fentanyl, that in nearly 70% of those cases, they also have alcohol in their body at the time of death. If we can discourage people from mixing drugs that were not prescribed to them by their doctors, then we can help save their life. As Tony Kane said, as long as there's breath, there's hope. Encourage first-person language within your facility. Native Americans suggested that I share with you. If you want to love something, call it a flower. If you want to destroy it, call it a weed. When we started calling individuals who had substance use disorders addicts and crack addicts, the prison population increased from 400,000 incarcerated in 1985 to 2.5 million by 2005, over a 20-year period. So we started changing our language. Persons with substance use disorder, persons with schizophrenia, and it changed everything. How we see people, how we treat people. We want to make sure that we honor the residents' level of readiness to change, using the 5-stage model we identified earlier, and honor multiple pathways of recovery. There are 23 million Americans who say they are in recovery. 2 million out of 23 million are in 12-step recovery. 2 out of 23 million people who say they are in recovery are in 12-step recovery. Here's your question. How are the other 21 million recovering? And there are many pathways. Solo recovery, faith-based recovery, medication-assisted recovery. There are cultural pathways of recovery. Native Americans have amongst the highest alcoholism rates in the world, and they are achieving some of the highest recovery rates in the world by returning to the culture that was taken from them. Some people recover one drug at a time. There's no one way. When we honor the various ways in which people recover, we engage them better. There's a pathway of recovery that's called a gender style of recovery. There are lots of women that have histories of trauma who feel really comfortable being in a recovery environment, primarily with women. It may feel safer for them where they can support each other's recovery. So we want to make sure that we honor those pathways of recovery. So Nikki, let me check in. So who has a question? And should they put their questions, where should they put their questions?
Okay, thank you, Mark. If you have a question, please place that question in the chat box, or you can come off of mute by raising your hand. You will see the symbol at the bottom of your screen. No questions as of yet. If you have a question.
Nikki, sometimes people are afraid to ask the first question. Let's hear from the person who has the second question.
Okay. Well, while we're waiting, I have a question, Mark. What would you say a benefit, you mentioned Narcotics Anonymous earlier. What would you say a benefit of residents participating in Narcotics Anonymous or Alcohol Anonymous groups?
Not only would I recommend that residents participate in the Nikki, I'd recommend that some of the facilities make the decision to have a meeting right there on the premises that make it easy for residents to access these services. Let me share with you all the story of a flight attendant who developed alcoholism, drinking those little bitty bottles of liquor they used to serve on airplanes. You know those small bottles of liquor, they were small, but they can get you drunk? Well, her employer smelled alcohol on her breath. So they forced her into treatment. And shortly after treatment, she took a short flight from Las Vegas to the international airport in Los Angeles. When she got off the plane, she had an unbelievable urge to have a drink. And she was standing near Terminal 12, and she saw that liquor to her left. She's about to have a drink. And then she ran over to the person holding the microphone to her right and asked that person, would she make an announcement? The announcement was, will all the friends of Bill W., and Bill W. is the co-founder of Alcoholics Anonymous, please report to Terminal 12. And she said that 20 people from all over the world showed up at Terminal 12, and they have a 20-person meeting right there at Terminal 12. What it does for you is it lets you know that you're not alone, that there are others who walk this path, and you can be supportive of each other in that recovery, right? So Alcoholics Anonymous was the first anonymous group. Then they formed one called Alateen. Before that, they formed Al-Anon. a support group for loved ones who have a relative that has alcohol use disorder, then Alateen for teenagers, Alatot for like little children that have parents who have alcoholism, Alapet for the dogs, only kidding, no Alapet. Narcotics Anonymous, Cocaine Anonymous, you're not alone. And because we know that the anonymous groups are not the only pathways, some facilities actually have what's called smart recovery groups on their premises. You know one difference between the two? Narcotics Anonymous, you make a statement like, my name is Mark, I'm an addict. My name is Sheila, I'm an alcoholic. But with smart recovery, you don't even have to say that you have it, because the label alone can carry stigma for some people. I had a colleague of mine whose husband had alcohol use disorder, but he struggled in AA meetings because it was hard for him to say, I'm an alcoholic. He said, well, there's smart recovery. He didn't have to say it. He's been in recovery for 5 years without having to say it by going to these meetings. Nikki,
Wonderful, wonderful. Yes, yes, we have one question in the chat. How can I assist a resident with severe PTSD and night terrors, along with high desire to heavily medicate themselves to treat those disorders? What would be the best first step to help them?
Let me share something with you, which as a group, which you might find kind of mind blowing, and this might even impact the kind of trainings that that the Center of Excellence decides that they want to provide for you. Are you all sitting down? I believe that almost everyone who lives in America is a historical trauma survivor, including all of you. Those of you with us today who have African ancestry, that means your ancestors endured 250 years of chattel slavery, Jim Crow laws, lynchings, right? I know I'm a descendant of the enslaved because my mother beat us like we were enslaved. Some of you hearing the sound of my voice have Native American ancestors. That's true for you. Your ancestors experienced over 200 years of massacre, land taken away, property taken away, right? Everything sacred destroyed, culture taken away, heavy alcoholism, historical trauma. Some of you are from California. And what was California called before it was called California? I'm glad you asked. Mexico. Listen to the sound of the cities. Los Angeles, San Bernardino, San Francisco, San Diego. There are 11 states in the United States that were either Mexico or part of Mexico. It was taken away, historical trauma. Some of you are refugees. Some of you have ancestors that were placed in internment camps during World War II. If you're their grandchildren, historical trauma. Some of you with us have ancestors that came to America by way of Ellis Island between 100 and 200 years ago. Why did they come to the New World? Escaping World War I, escaping World War II, escaping Hitler, religious persecution, famine, starvation, war, incarceration. We are all, and so are all of your residents, historical trauma survivors. If we threw trauma on top of what we've been talking about, ultimately mental illness, then those numbers of clients or residents with co-occurring disorders would be much higher than the 50%. The smartest thing we can do, if we were not having this conversation today, would be to make sure that our facility, a nursing facility, became a trauma-informed system of care. Whether you have residents that have co-occurring disorders or not, we make sure that we create a safe sanctuary so that healing can take place in that sanctuary. If we became a trauma-informed system of care, then all of our staff will be trained in trauma-informed care. So it wouldn't just be the person who asked the question, but all of us. So in response to your question, is to learn as much as we can about trauma-informed care, and then to help the resident, that person who struggles to sleep at night, right? Because of PTSD symptoms, begin to manage some of those PTSD symptoms. And some of the best practices out there are those mindfulness approaches, meditative type approaches. Those types of approaches have been helpful, cognitive behavioral therapy approaches in helping people to manage those symptoms. We want to, in a situation like that, we want to reframe their substance use as a coping mechanism. This is a coping mechanism for you because it's helping with the symptoms of PTSD. At the same time, we know that it can make those symptoms worse. We want to help you find some other methods of coping. So I'm going to turn this over to Nikki in 31 seconds, but every day I want you to walk through the world with your head held high. And people are going to see you with your head held high, and they're going to say, look at her. She thinks she's a gift to the world. Look at him. He thinks he's a gift to the world. And you know what you are? You've been given those gifts to make the world a better place. And you're using your gifts to make the world a better place. Thank you so very much for all that you do. I turn it over to Nikki.